This video we're going to be talking about process in swallowing, swallowing reflex, steps in swallowing, the upper esophageal sphincter, the lower esophageal sphincter, and as well as some disorders and some terminology with regards to anatomy. So first let's just do a general about swallowing reflex. So the swallowing reflex is controlled by the brainstem. There's the swallowing center in our brainstem that controls everything when we are swallowing a food bolus. Then it's important to know that initiation is voluntarily. So when we put the food in our mouth and we're chewing it, that's voluntarily. But the remaining contractions that move our foodstuff bolus into the stomach, those are all involuntary. We have no control over it. And then we have peristaltic contractions, where we have regional contractions designed to prevent food from entering respiratory pathways. So to show some of these respiratory pathways and GI pathways in our model that I drew here, so right here where I've labeled 1, this region is called the nasopharynx, and it's solely respiratory. No food should be going up here. But sometimes we do see that. That's when food comes out of the nose or liquid. Then we have right here region 2, where this is our oropharynx, and then region 3 here is our hypopharynx. The oropharynx and hypopharynx are both respiratory and GI pathways. Right here I have the trachea, and in the green here, right here I have the upper esophageal sphincter, and then these green lines I have here is our esophagus going down. And then we have this yellow thing here, which actually comes down and closes on to the voice cord, so that food does not go into this pathway, into our lungs, so we don't choke. And then right here in red, this is very important. It's one of the contractions that we have when we eat. When we have a contraction, it's the skeletal muscle, this comes up and blocks off these two regions, so there's no pathway in between them once we have a contraction, when there's a food going down into our stomach. But sometimes there are stroke patients that when they eat this, they don't have the ability to contract their soft palate, so food usually goes up into their nasopharynx, and then you see food coming out of their nose. Now, the soft palate is involuntary when we're swallowing. We don't choose to contract it or not, but when we make sounds like the k sound, that's voluntarily. As well as this epiglottis here. When we make gagging noises, that's a voluntary control of the epiglottis. And to better understand the epiglottis, it's kind of like a toilet lid when it's closing down. Kind of, if there's a bolus coming down here, it just hits this and makes sure that it does not go into our respiratory pathway here. So this will come down. It doesn't just stay up here. It just comes down when a bolus is coming down to go into our stomach through the esophagus. And the epiglottis as well as the soft palate are both skeletal muscles. And in this region, our laryngeal region, that is where our voice box sits. And if you see a video of a scope going down, you can see this in action. The epiglottis coming down, you'll see that that's contracting, and you'll see when they make certain noises and sounds. The voice box has different shapes to it right here, right before the trachea. So now we're going to go into the steps in swallowing. So in the steps in swallowing, we have phase 1, which is the oral phase, where we have the tongue pushing the food against the roof of the mouth. And when the bolus is pushed upwards and back to the roof of your mouth, this is a touch information. The tongue to the roof of the mouth goes to the swallowing center in our brainstem, where we talked about right here. And then you no longer have control. It's involuntary from here. So the brain takes over, and then we start to have peristaltic-like contractions of the tongue once it hits the roof of the mouth. And at the same time, the soft palate goes up, it contracts, and this goes up and blocks off these two regions, the nasopharynx and the oropharynx. And for a moment, we stop breathing while the soft palate contracts, and at the same time, the upper esophageal sphincter right here starts to open, so food can go down. So this is closing, this is going up, and this is opening once we have a food bolus into our going into our throat. The opening of the upper esophageal sphincter, it's said that it starts to open at the end of our oral phase, but we have it opening in the pharyngeal phase. So in that pharyngeal phase, which we just talked about, this closes right here. The soft palate goes up and contracts. We stop breathing, but our upper esophageal sphincter is open. And then we have the esophageal phase. Before we go into that, the peristalsis within oropharynx and hypopharynx helps push the food bolus down towards the open esophagus right here, of esophageal sphincter here. So we have peristalsis-like contractions happening here. And then in our esophageal phase, the upper esophageal sphincter closes, and then we resume breathing, and then we have peristalsis contractions trying to move the food down to our stomach. So the purpose of our upper esophageal sphincter is to prevent damage from stomach acid, and there's a very high pressure sphincter. It's about 40 to 100 millimeter of mercury. This high pressure is because it prevents reflex from our stomach to our mouth, and it prevents air from entering GI tract. It's also important to know that in the esophageal phase, sometimes if our first peristalsis fails, so if we're having medicine and maybe it gets stuck somewhere, we have secondary peristalsis induced. It's just, there's no tertiary or quaternary, it's just more contractions. We just keep contracting it until that food stuff or the pill, whatever you just had, goes into your stomach. And sometimes in this esophageal phase, the lower esophageal sphincter starts to open within this phase, so for the entrance into the stomach. And with the upper esophageal sphincter, we have the vagus parasympathetic nervous system involved, and also when you do inspiration, it increases the tone, and it shows our ability that it can contract and prevent damage from the acid coming back into our mouth. So now our food bolus that was here during this whole time we were talking about swallowing is now in our esophagus. And our esophagus is basically a transit tube from our mouth to our stomach. It's about 18 to 25 centimeters. We have 3 regions in the esophagus. The first region is the upper 1/3, and that's skeletal muscle. And then we have the second, the middle region is a mix of skeletal and smooth muscle. And then our lower region, closer to our stomach, is only smooth muscle. This is seen in humans, but in dogs, their esophagus is 100% skeletal muscle. And we've already talked about the upper esophageal sphincter, but our esophagus is bordered on top by the upper esophageal sphincter, and then the lower portion of our esophagus is bordered by the lower esophageal sphincter. And as we said before, the upper esophageal sphincter has a very high pressure. It's 40 to 100. But our lower esophageal sphincter is very low pressure compared to the upper. It's very low in tone. But if you look at where the lower esophageal sphincter is, our diaphragm is right around it. And so tone increases with inspiration. So the diaphragm squeezes around it and increases its tone. And then in our lower esophageal sphincter, we also have the myogenic contractions, which is muscle contracting on its own automatically. And then also our tone increases with food load, when we have food in there. And then also, like the upper esophageal sphincter, our regulation is by the vagus nerve may be involved. They're not positive, but we know the vagus nerve is involved because when a vagotomy was done, their lower esophageal sphincter was not working. The same with upper esophageal sphincter. That's how we know that the vagus nerve is involved, because when a vagotomy is done, the contractions are not working anymore. Also, we have intrinsic nervous system involved. The intrinsic pathways are there to help relax it, causing the sphincter to open up. Okay, so now we're going to talk about some controls and inhibition and how we handle liquids. So we have, when we guzzle, it's called guzzling liquids. It means when we're taking many gulps. So the liquid loads up the upper esophagus, and then when we're taking many gulps and gulps until we can't, and then we have our last swallow, and then we have a big peristalsis. Let me just write that for you. Alright, so that's our guzzling liquids. And so we also have what I have put here. It's called deglutitive inhibition. It's basically a relaxation in our esophagus. So we have these background contractions that are going on, but when we have a deglutitive inhibition, it's so that we continue to stretch the esophagus until it can't, and then we relax it, and then it goes into our stomach. It's detected in our throat, and it's a contrast to peristaltic contractions. And we do this to prevent the secondary peristalsis from happening, so we don't have to keep on contracting and contracting until the food comes out. We just keep on stretching the esophagus, fit as